small left hearts, small right hearts, hearts that for one reason or another aren't very suitable for two-ventricle repair. So we're going to start with left heart abnormalities, left heart hypoplasia. And what I mean by that is left heart structures that, including the mitral valve, left ventricle, and aortic outflow, are collectively too small to support the systemic circulation at an acceptable filling pressure. There are some hearts that can actually provide a barely adequate cardiac output, but can only do it at a filling pressure of 25 or 30, which isn't survivable for long periods of time. And then there are other hearts that simply can't begin to provide, or left hearts that can't begin to provide an adequate cardiac output. So here, this is classical hypoplastic left heart syndrome. There's common mixing, systemic and pulmonary venous blood coming together into the atrium and right atrium, right ventricle, and then being pumped out, generally a pulmonary artery, and the ductus supplies the systemic circulation. So this is a ductus-dependent systemic type of circulation. And this is an example of a heart like this with aortic atresia and mitral atresia. You see the very tiny ascending aorta over here to the right, a larger pulmonary trunk, and a large ductus arteriosus up here that really supplies the body. Here are the branch pulmonary arteries inside. And here we see the connection to the aorta. Here's the foraminal valley from the left side. You can see that it is quite valve competent. It doesn't extend very far over, so blood would have a hard time getting out of this left atrium, which we know is often the case. There's the atrial appendage here. And if we look down, there's a tiny little orifice here where the mitral valve should be, but there's mitral atresia. There's no opening in this little orifice in the base of the left atrium. And this is where the tiny left ventricle is. That's really all there is to the left ventricle there. It's buried in this massive muscle on the back of the heart. And there's a pea-sized chamber here with no inflow and no outflow. So this is really classic hypoplastic left heart syndrome, mitral atresia, aortic atresia. Here's another example of mitral stenosis aortic atresia. There's a small ascending aorta. Here you see the foraminal valley, which is also a little bit tight here. There's just a small opening at the top there, right there. Eustachian valve here, coronary sinus in the right atrium. So the right atrium looks fairly large in this patient. The appendage, pectinate muscles around the tricuspid orifice there. So this is tricuspid orifice down into the right ventricle. Now this is a very dilated right ventricle. This was a couple of months or 3-month-old patient. And notice the papillary muscle here and the chordae make a big angle with the usual orientation of the valve from base to apex. And this holds the valve open, and this contributes to tricuspid insufficiency in these patients with big dilated right ventricles. There's the septal leaflet of the tricuspid valve there. This is a big anterior leaflet up here. This is the parietal band. You can see some of the usual structures in the right ventricle, but this is a very bizarre looking ventricle. A lot of these right ventricles are. Here's the tiny left ventricle with the small mitral apparatus here, just a few cords coming down to a very small group of papillary muscles close together here in the ventricle. There was outflow atresia. Here's the left atrium again with the foraminal valley up here, there's septum primum, which overlaps pretty much with septum secundum, again making it difficult for blood to exit from this left atrium. This aortic atresia mitral stenosis group are the patients, there's the appendage, are the type of patients who often have coronary connections to the left ventricle. And here's this tiny ascending aorta with brachiocephalic arteries up here coming off the aortic arch. There, there. And then we'll see into the, this is the ductus coming into the descending aorta, and you can see right here This is going back to the ascending aorta. There's a coarctation ridge. And most of these patients have coarctation. And so using the ductus, some of the hybrid procedures that are done using the ductus to expect blood to go backwards into the ascending aorta may not be so realistic without doing something to that. This is, again, mitral stenosis, aortic stenosis. It looks like an atrial septal defect has been created in this patient. The lower edge here looks sort of ragged as though it's been cut away surgically. And looking down into the tricuspid orifice, this is a little more compact right ventricle. The papillary muscles are organized a little more reasonably for the tricuspid valve. There's the papillary muscle of the conus. This is infundibular septum. Pulmonary valve is up here. This is the parietal band coming out to the free wall. But you see how muscular and how muscle-bound it is. Now this is the little left ventricle. You see there's endocardial fibrosis. It's very slick and shiny. There's marked hypertrophy. And here are the two papillary muscles on the free wall of this ventricle. And this is an arcade-type mitral valve, which we often see in these patients. You see there's just a thick ridge here at the base of the anterior leaflet going from papillary muscle to papillary muscle with no chordae and direct leaflet attachments onto the two papillary muscles. The posterior leaflet's in the back here. So this is an arcade type of mitral valve. These often have mitral insufficiency if there's enough of a ventricle to produce insufficiency. Here's the outflow tract up here. There is an aortic valve. It is patent if we look at it from above. This is the aortic valve there. I think it's had a balloon dilation. You can see there's a little tear right here in the valve. So this is a very abnormal aortic valve was unicommisural, and now there's been a balloon dilation which has made a tear in it. Okay, thank you. So this is another mitral stenosis, aortic stenosis. There's a larger interatrial communication in this patient, superior vena cava up here, the right atrium, and down into the tricuspid valve. You can see the appendage here, typical right atrial appendage, and a view down into the tricuspid valve in this patient. Coronary sinus there. And again, you can see there's a larger interatrial communication here. Now here the tricuspid valve looks a lot more normal, a lot better. There's a papillary muscle of the conus up here. You can see the outflow musculature up here. The pulmonary valve is up there. So the morphology of this ventricle looks a little more normal than some of the other ones that we saw previously. There is hypertrophy, as you would expect, since this is a systemic ventricle. And here's the left atrium with, again, a larger interatrial communication. The atrial appendage is up here. Pulmonary veins coming into the back of the atrium back here. And the left ventricle is a little bit bigger in this one. The mitral valve looks more normal. There's some hypertrophy of the papillary muscles, and they're very closely spaced here on the free wall. And this is the aortic outflow up here. So this really looks like not such a bad looking left ventricle. Here's the aortic valve up here. It's a very abnormal looking aortic valve with just a central opening in it. This patient had undergone pulmonary artery banding. This was an older specimen. And here you can see the ductus coming into the descending aorta. The isthmus area here is quite small. And again, you see the ridge right here, typical for coarctation, so that the ductus that comes in distal to that would have trouble retrograde filling the ascending aorta and the brachiocephalic arteries because of the reverse coarctation. I just put up some criteria that have been established or proposed for deciding which ventricle is too small, and here you can see these are criteria that we had published a number of years ago using multiple left heart structures. This is just based on volume. And then Dr. Silverman's group has proposed, and I think it's a very good indicator, retrograde flow in the aortic arch. The criteria that we had published, Steve Cullen recently, a few years ago now, evaluated those and redid them a little bit, I think because we realized we were pushing too many people toward a two-ventricle repair. And it still uses multiple structures, aortic annulus, LV long axis ratio, but they introduced the idea of trying to grade EFE. And I finally just want to make one point here. If you look at each of these criteria individually, these are survivors, these are patients who either died or underwent a single ventricle palliation. You can see that there's marked overlap of all of these things, so that no one of these criteria is particularly useful for distinguishing between these groups of patients, and that's why I think it's important that one use multiple criteria. And these patients generally need some kind of Norwood-type operation, unobstructed pulmonary venous egress, using the pulmonary outflow tract as the systemic outflow tract, and then creating some sort of stable source of pulmonary blood flow.
While Dr. Silverman's getting that ready, I'd just like to make a few preliminary comments. And the first one is that I really don't think we should use the term single ventricle as an overall description of the various types of single ventricle, because if a single ventricle is the left ventricle or the right ventricle, it's very different, and we shouldn't try to lump them together. The second point I'd like to make is I don't like the term hypoplastic left heart syndrome, because there too it embodies a whole range, a whole spectrum of different conditions, and we should talk about it the way we see it. So it's aortic atresia or mitral atresia or both, and we should not try to lump things together because it makes confusion rather than clarification. With that, we go on. As you see, I'm talking about aortic and mitral atresia, and I put hypoplastic left heart syndrome as emphasis. Now, we don't know what causes hypoplastic left heart syndrome, but it is interesting that there are two genetic considerations that one should take into consideration. Firstly, in the Netherlands, there was a study done in pigs in which they found that a particular family of pigs had a very high incidence of what was called hypoplastic left heart syndrome. And these pigs, the offspring of these pigs, very frequently developed hypoplastic left heart syndrome. So there obviously was some genetic relationship. The second thing is, what makes the left ventricle develop? Well, genetically, on the basis of Olson's work, there is a gene, the hand-2 gene, which is very important in left ventricular development. And if there's an abnormality of the hand-2 gene in mice, the left ventricle may not develop, and the fetuses die. So with that preliminary consideration, what I'd like to go on again is to discuss this in terms of hemodynamic considerations. And I've been using that theme all the time I've been discussing these conditions with you. So I'd like to continue with that discussion. Now, we were able to show in experimental animals, in lambs, fetal lambs, that changes in blood flow could influence development of the chamber, ventricular chamber. Now, we know this had been shown previously in small animals in rats, that when the inflow to the left ventricle was interfered with, and that was by interfering with foramen ovale flow. This was work by Olga Harrig. It was shown that the left ventricle was small. Then, in our lab, Noel Fishman did 2 studies in which we did these studies in fetal lambs. The first one, we prevented inflow into the left ventricle by inflating a balloon in the left atrium and interfering with flow into the left ventricle. In the second study, we reduced outflow and inflow into the left ventricle by producing a stenosis of the ascending aorta just above the valve. And what we found was, both with reduced inflow and with reduced outflow and inflow, the left ventricle was small. And here you see this. There's a control lamb with a left ventricle and the right ventricle. And here's a lamb in which the ascending aorta was banded. You see this reduction in left ventricular size. Now, this was not only a reduction in ventricular size, but also a complete change in muscle. There was a change in the muscle, in that the muscle in the left ventricle showed hyperplasia, and after some time developed some collagen change as well. So, based on this, we also know from the originally shown by Lisa Hornberger that in humans, where there's outflow stenosis, in human fetuses with aortic stenosis, that if you follow them, you see in some of them a progressive decrease in left ventricular size. So it seems that the development of the chamber is important in relation to blood flow. Now, of course, as you know, I'm not going to go into the discussion of that today, but it is this work which led to the concept that if you relieve the aortic stenosis in the fetus, you could allow the left ventricle to grow, and that's the basis for the work that's now being done in many places, but particularly in Boston with Wayne Tworetsky, in which they are doing a balloon dilatation of the aortic valve, where the diagnosis of aortic stenosis is made in the fetus and where the ventricle is small. So I think, again, this introduces the concept that some of these problems may not be present initially, but may develop. So the concept then has been that the primary problem is probably in the aortic valve. But we really have to consider another possibility, and that is that the primary problem is in the heart muscle. Now, when we consider this, if you look at all the studies that have been done looking at fetal heart in fetuses that develop small left ventricles, it is found almost always that by the time the diagnosis is made, there is a disturbance in left ventricular function. So the question that one has to ask is that the primary problem rather than the stenosis? And the question then is it possible that the stenosis is the secondary development and that the primary problem is a problem of muscle, such as a fetal myocarditis or something like that, or some other problem in myocardial development. And if we discussed this morning the fact that we know that, like in Epstein's malformation, where there's a poor output from the ventricle, the valve can become occluded, and atresia of the pulmonary valve can develop as a secondary phenomenon. So is that possible, that with left ventricular dysfunction, if an inadequate output of the left ventricle is developed because of the muscle dysfunction, and there is a large ductus with the pressure from the pulmonary artery transmitted to the aorta, that may cause aortic valve closure. So those are things which we have to consider, and we really don't know the answer yet to these. But when we consider the presence of aortic atresia in the fetus, Dr. Sanders mentioned something about the blood flow pattern, and I'll just elaborate on that. Here you see that when the aortic valve is completely sealed off, in the fetus, the blood returning to the heart from the venous system and from the umbilical veins all has to go into the right ventricle, and then is ejected through the pulmonary artery. And because there's no blood coming into the ascending aorta, the supply of blood to the whole body has to come through the ductus arteriosus, not only to the systemic circulation, but also blood flow to the lungs has to come from there. So the total cardiac output comes from the right ventricle. And what's interesting is that because of this complete admixture, because pulmonary venous return comes back to the left atrium, and it has to also enter the right atrium to be ejected, so that there's total admixture of all blood from the body. And as I've mentioned repeatedly here, my estimate when there's complete admixture of blood in the fetus is that the mixed saturation is about 55%. So this would mean that the blood going to the lungs would have a somewhat higher saturation than normal. The blood going to the brain would have a somewhat lower oxygen saturation than normal. And I'll mention this again as to the implication of this. Now, as I said, all the total output is ejected by the right ventricle. Now, normally, the right ventricle ejects in the human fetus about 55% of the combined ventricular output. Here, it's ejecting 100%. So it means that right ventricular output is almost double what it normally is. So the right ventricle is working very hard in the fetus to maintain output. The other thing that is important is what was mentioned earlier too, is that aortic coarctation is extremely common in association with this. In a study done many years ago, it was a pathological study, they estimated that about 80% at least of babies who had hypoplastic left heart syndrome or aortic atresia had a coarctation, and in most cases it was quite severe. Now it's interesting in relation to what I mentioned this morning. You asked, well, why is coarctation so common? Well, you could say it's because it's part of the developmental anomaly. But on the other hand, if you consider the dynamic factors that I mentioned, you see that in aortic atresia, there's no blood going up into the aorta from the left ventricle. There's a huge flow going across the ductus, so that at the junction of the subclavian and the descending aorta, is where the ductus flow is going. So that high flow, again, it's the Hutchins concept of the development of coarctation. So it's perfectly reasonable that you should expect coarctation so commonly because there's this huge flow going through the ductus. In fact, normally the ductus arteriosus in the human fetus carries about 30-35% of combined ventricular output. Here it's carrying 100%. So because of that, the ductus is huge, which is what you'd expect if it's carrying so much blood. Now, one of the interesting things that has been addressed recently is the fact that we've begun to realize that there's a very high incidence of cerebral developmental problems in babies with hypoplastic left heart syndrome. And at first it was thought that they have such a difficult time after birth that this was probably related to damage to the brain because of surgical problems, perfusion problems, and it was thought that this developed postnatally. We know now, however, that this is not the case because, first of all, it's been observed that babies with hypoplastic left heart syndrome have a small head circumference in relation to body size. Secondly, more recent studies have shown that if you look at the brain with MRI, you find abnormalities during fetal life. Beyond about 30 weeks gestation, there is a progressive increase in brain abnormalities noticed in these fetuses. And there's been one very nice study done again from the Boston group by Limpropoulos, in which she looked at MRI of fetuses and found not only these abnormalities, but also metabolic disturbances in brain function. So it's obvious that there's something about these fetuses that is causing that they're developing brain problems before birth. And what has been suggested, there's a study by D'Onofrio and Kleiman in which they looked, we mentioned yesterday about pulsatility index in the cerebral arteries. They noticed that there was a decreased pulsatility index in the cerebral arteries, and as I mentioned, this is interpreted when there's a decreased pulsatility that it's related to cerebral vascular resistance. And they proposed that cerebral vascular resistance was decreased because there was vasodilation in response to the hypoxemia which was present, because I mentioned the blood going to the brain has a low oxygen saturation. Now, I don't believe this because the oxygen saturation of the blood going to the brain, normally in the human fetus it would be about 65%. Here it's about 55%. I don't think that this degree of reduction in oxygen saturation could cause these brain difficulties. It may cause some cerebral vasodilatation, because studies we've done in fetal lambs, we've produced severe hypoxia, and we find that cerebral blood flow increases dramatically with hypoxia, so that we've dropped the PO2 in the blood perfusing the fetus from the normal of about 28 going to the brain to as low as 10 or 11, so that oxygen saturation dropped from about 65 down to about 20. And in spite of the fact that this low oxygen saturation of blood going to the brain, the brain blood flow increases so much that when we measure oxygen consumption of the brain, it's normal. It doesn't change. So that I don't believe that this small decrease in oxygen saturation is causing the problem. My belief is that the cause of the brain problem is the coarctation. Because if you think about how does the brain get its supply? In aortic atresia, the blood going to the brain has to come through the ductus, across the aortic arch, and then up to the cerebral vessels. So it has to cross the coarctation. Now, it's very interesting that if the evidence at the moment is that coarctation is manifest predominantly in the last trimester of gestation, beyond about 30 weeks. And that is when you see the brain problems beginning to develop. And I think that the demonstration of the low pulsatility index is not due to cerebral vasodilatation and decreased cerebral vascular resistance. There probably is decreased cerebral vascular resistance, but I think the decreased pulsatility index is because of the coarctation, because coarctation decreases pulsatility index. So I think we have to really think this through very seriously, because it may have tremendous impact on how we handle these problems in these babies. Now, I've mentioned the overall circulation, but there's some very important issues we have to take into consideration in regard to the circulation. Remember that the two normal fetal channels, the ductus arteriosus and the foramen ovale, are very important in this lesion, because the ductus carries all the blood to the body and the lungs. The foramen is important in carrying blood from the lungs back to the heart, to the right atrium. Now, as Dr. Sanders showed you, the foramen is very interesting in this condition, because the flap of the foramen is usually well developed. So it's very likely that with the blood coming back, all the blood from the lungs coming back through to the left atrium, it has to go the wrong direction. Normally blood through the foramen goes from the right side to the left. This has to go in the opposite direction. And if there's a well-developed flap of the foramen ovale, that's going to potentially result in obstruction to flow, or restriction of foramen ovale flow. Now, what happens with that? Left atrial pressure will increase, and when left atrial pressure is increased, we know that that stimulates an increase in pulmonary vascular smooth muscle development and pulmonary hypertension. So you see these things all relate to one another in terms of what the effect is of these lesions. The other important point is that if it has been shown by a number of people, but initially by Lisa Hornberger, that you can get a good idea of whether there is restriction of the foramen ovale by looking at pulmonary venous flow pattern, the Doppler examination of the pulmonary venous flow. If you see that there's good forward flow, but with very little reverse flow during atrial systole, that means that there's not very much restriction. On the other hand, if you see low forward flow and marked backflow during atrial systole, that means there's a lot of restriction. And this has been a fairly good index of what the degree of restriction of the foramen ovale is. Now, what about the pulmonary circulation? Well, it's interesting that you have now two conflicting factors which potentially affect the pulmonary circulation. On the one hand, I mentioned to you that normally the oxygen saturation of blood going to the lungs is about 48 to 50%. So here, that oxygen saturation is somewhat higher. You say, well, 5% is not important. But from studies we've done in fetal lambs, we know that small changes in PO2 of blood going to lungs produce dramatic changes in pulmonary vascular resistance. So that I think that this is enough of a change to cause, it's an increase in oxygenation, so it would cause a decrease in pulmonary vascular resistance, which would increase pulmonary blood flow. Now, I mentioned to you that on the one hand, we have an increase in pulmonary blood flow. On the other hand, if there is pulmonary hypertension due to left atrial pressure increase, then that would produce a reduction in pulmonary blood flow because pulmonary vascular resistance is increased. So I think you sort of, in these fetuses, a balance develops between these two opposing factors that are influencing pulmonary vascular resistance. Now, the other important issue is that because of this coarctation, in the same way that potentially it can affect cerebral blood flow, this could also affect coronary blood flow. And possibly, with a decrease in coronary blood flow, you may get damage to myocardial function. Now, I think it's really important to recognize, I just want to stress again, the cerebral circulation factor, because if you think about this, if it's not only a reduction in oxygen supply, we concentrate on oxygen supply, but if there's a reduction in blood flow, there's also a reduction in what I mentioned yesterday, and that is glucose supply, and that is the main substrate. And the studies that have been done in cerebral metabolism suggest that there is a problem in metabolic substrate supply. So it's really a combination of both oxygen and substrate that's important. Now, postnatally, we have a whole series of problems. And here again, there's a whole complex of issues that can affect what happens to the baby postnatally. And the factors that are important in determining how the baby is going to react are what happens with the ductus arteriosus, what happens with the foramen ovale, what happens to pulmonary and systemic vascular resistance, and, of course, the coarctation. I'd just like to stop here for a moment and go back to something that I think that I didn't mention that is important, and that is that I mentioned the fact that foramen ovale restriction or closure can occur during fetus. Now, we know that when that occurs, if you find foramen ovale restriction in the fetus, this is bad news, that these fetuses may die in utero, or if they are born, they very frequently die immediately or soon after birth. And this is because of this, there has been fairly recently an attempt to open the foramen, to relieve that restriction and try to prevent the damage to the lung vessels that occurs. And this has been done successfully in a number of fetuses. I think the results are still open to some question. But because of the concept that the foramen ovale restriction is causing this problem, this is an attempt that has been made recently. Now, it's one thing that's important, very important in the postnatal situation as well as in the prenatal situation. there is still complete admixture of pulmonary and systemic venous return. Prenatally, it's the mixture of umbilical venous and systemic venous return that determines oxygen saturation. Postnatally, because there's complete admixture of pulmonary and systemic venous return, it's the ratio of pulmonary to systemic blood flow that determines what the oxygen saturation is of blood delivered to the body. And I think it's very important for you to remember this concept of pulmonary to systemic blood flow ratio, because that determines much of the physiology of what happens in these babies. So, what's the role of the ductus? Well, obviously the ductus is important, because since the left ventricle isn't ejecting any blood, the only way you can get blood to the body and to the lungs is through the ductus arteriosus, from the aorta through the ductus. And so that, as I mentioned, you have to have blood going from the aorta, from the pulmonary artery. Now, if you think about this, it's really interesting that the pulmonary artery is supplying blood both to the lungs and to the systemic circulation. The systemic circulation is supplied through the ductus arteriosus. So now, with the same common pressure chamber ejecting blood into both circulations, the volume of blood flowing to each circulation is going to be determined by the vascular resistance. Now, the vascular resistance of the pulmonary circulation is there alone, but the vascular resistance of the systemic circulation is both the peripheral resistance plus the ductus resistance. So that if the ductus constricts, it's going to limit systemic circulation. It will not limit pulmonary circulation. In fact, if the ductus constricts, the higher pressure that develops in the pulmonary artery will increase pulmonary circulation. But if the ductus constricts, there'll be a lower pressure in the systemic circulation and there'll be decrease in flow to the systemic circulation. By the same token, if there's a change in resistance in either the pulmonary or the systemic circulation, this will alter the distribution of blood ejected by the right ventricle into the pulmonary artery. So that if systemic vascular resistance falls, there'll be more of the blood ejected from the pulmonary artery that goes to the systemic vasculature. If pulmonary vascular resistance falls, more will go to the pulmonary circulation. So that you can appreciate then that there's this fine balance that's going on all the time as to whether you get blood to the pulmonary circulation or the systemic circulation. And these are determined by the ductus, degree of constriction of the ductus, and by the relative changes in systemic and pulmonary vascular resistance. Now, this is really very important as well in terms of what happens to oxygen saturation. Because if pulmonary vascular resistance doesn't change and systemic vascular resistance increases, you will get more blood flow going to the pulmonary circulation and less going to the systemic circulation. So that means that pulmonary to systemic blood flow ratio increases, and that means that the oxygen saturation of the mixed blood will go up. On the other hand, if there is a decrease in systemic vascular resistance and no change in pulmonary vascular resistance, the blood flow to the systemic circulation will increase and blood flow to the pulmonary circulation will remain the same, so that oxygen saturation will go down. Now, you would, based on this, you'd say, well, gee, we must do something to maintain oxygen saturation. We must increase the systemic vascular resistance. But you see, there's the problem. Because if you increase systemic vascular resistance, you decrease blood flow to the systemic circulation. So you get into this fine balance now. You need oxygen to go to the body, to the tissues of the systemic circulation. If you increase systemic arterial oxygen saturation by decreased systemic blood flow, that's fine, but the total amount of oxygen delivered to the tissues may fall even though oxygen saturation goes up because blood flow falls. And therein lies the problem of how we deal with these patients. If the ductus is wide open, systemic circulation will be well maintained. But if the ductus closes, you'll get more pulmonary blood flow and you'll see an increase in oxygen saturation, but it may not be enough to overcome the drop in systemic circulation you get. And this is typically what happens. If we give oxygen to a baby with hypoplastic left heart aortic atresia syndrome, you get very happy because you see oxygen saturation go up, but the baby develops acidemia because blood flow to the tissues is falling. And it's really an interesting situation that, we always tend to look for oxygen, we look for PO2 and say we need a good PO2. Well, if you get a good PO2, that's all very well, but we have seen babies, and it's interesting also that when you get this increase in oxygenation with an increase in pulmonary to systemic blood flow ratio, that under those circumstances, when you give oxygen, the PO2 can go up to enormously high levels. Mostly with complete admixture, you can't get PO2s much above 80 or so to 90. But when you have this situation, because pulmonary blood flow stays high and systemic blood flow falls, with giving 100% oxygen, we've seen PO2s go up to 250 to 300, even though there's complete admixture. And that's because with the high PO2, the ductus constricts, pulmonary blood flow goes up high, and flow to the body is low. And so these babies develop severe metabolic acidemia, even though the blood PO2 is up at 250 to 300. Now, another interesting thing is the same applies to what happens to arterial pressure. We obviously need arterial pressure to perfuse the systemic circulation. And it's very common practice in newborn infants to use something to raise pressure. If pressure's low, so in these babies, you have, if the ductus constricts, the pressure in the aorta falls because flow into the aorta falls. So the tendency is raise pressure, give them something to cause a rise in pressure, usually catecholamines. Now what happens is most catecholamines cause peripheral vasoconstriction. So what is happening now is that you have peripheral vasoconstriction already, you produce more peripheral vasoconstriction, you may raise pressure somewhat, but perfusion is decreased because of the peripheral vasoconstriction. So it's very interesting to understand what the dynamics are in these babies in terms of how you manage them. You have to think about the potential problems that may occur in these babies. Now, I told you, we mentioned that oxygen constricts the ductus and may be very bad for these babies, even though PO2 may be sky high. And the next issue is the foramen ovale. We've talked about the ductus, we've talked about pulmonary systemic vascular resistance. Now, what about the foramen? Now, I told you, we mentioned that in the fetus, that if the foramen is restricted, that's bad because it increases the amount of fluid in the lungs and also increases pulmonary vascular resistance. Now, after birth, remember that before birth, pulmonary blood flow is low. So the amount of blood that's required to go across the foramen is relatively small. But after birth, and even though the foramen may not have any restriction before birth, after birth, pulmonary blood flow goes up very high. With ventilation, there's an enormous increase in pulmonary blood flow. Now that pulmonary blood flow all has to return through the foramen. So you may have a fetus who has no foramen ovale restriction, but after birth, this may become manifest and result in severe pulmonary edema because there's an increase in left atrial pressure, and you may get pulmonary edema developing after birth because of foramen ovale restriction. I've talked about that. Now, the last thing I wanted to talk about is coarctation. And I've already mentioned this as an important factor, but I think that it's interesting. You know, we talked about in relation to brain blood flow, but it's also interesting that it may be an important contributor to some of the problems that occur postnatally in these babies. We don't know if baroreceptor function is normal in babies with aortic atresia. We know that in the normal fetus and newborn, baroreceptor function is very active at the time of birth. Now, if there is normal baroreceptor function, then what you might expect, if there is a coarctation, pressure in the ascending aorta and carotid vessels will be low. This will stimulate baroreceptor function, which will result in sympathetic stimulation and in catecholamine release, which will cause peripheral vasoconstriction and limit systemic blood flow. So we don't know whether this is normal, but it's an important question that we have to ask because it certainly would contribute to the problems that these babies have. Well, I think I've talked enough about this problem, so I'm going to stop there.
It's a daunting task to have to follow you. I'm going to talk about some really mundane things, and I'm going to talk about them very quickly. I hope. If I can get my set on, I'll be okay. Just put this in here. I think I'm okay. Thank you. Here we go. I assigned myself 10 minutes here, which was totally unrealistic. I must have had a mental lapse. So I'm going to still try and do this as quickly as I possibly can, but I think we have to be fair to you and show you what the data is all about. So I'm not going to worry about classifying it, and I won't talk about the post-operative findings after Norwood procedure because I think we're going to run out of time. Basically, you know that there are 4 types of this entity, which we could call bananas, and that way we don't offend anybody. There's aortic atresia with mitral atresia, in which case the left ventricle is more than likely absent. Hypoplastic left ventricle with mitral stenosis and atresia, a left ventricle with aortic and mitral stenosis, and of course there are other types that have a dilated left ventricle, that have venous anomalies such as total anomalous pulmonary venous return or levi atrial cardinal vein, and also patients that have ventricular septal defects, and that presents somewhat of a large problem to us. And of course, as Dr. Rudolph has just shown us, you can't forget what happens in the fetus. So what are our goals? Our goals are to determine the anatomic components, to look at the septa, to evaluate particularly the atrial communication in the pulmonary veins, watch for flow around the aortic arch, assess the size and function of the right heart, and coronary imaging and flow characteristics, and then to see associated lesions. So let's just look at a couple of pictures, and here is a very hypoplastic ascending aorta. You can see that not only is the aorta hypoplastic, but there's retrograde flow in the transverse aorta. And I've put a specimen down here oriented to show you the long axis view and the very small size of the aorta that's often 2 or 3 millimeters. You can see how terribly small it can well be. And of course, to some extent, the size of the aorta is a prognostic factor when it's very small. You can see here the origin of the right coronary artery arising off the ascending aorta. And we can look at the aorta from a variety of planes. Here we're looking at long axis as well as short axis planes, and you see the very hypertrophic right ventricle that has occurred as a consequence of a long high load that it's handled in fetal life. And sometimes you can even see, as we see here, an aortic valve which sometimes has a minimal degree of flow and sometimes is even associated with stenosis. And you can see this little jet coming out of this abnormal aortic valve. And of course, it may be larger. Now, in the short axis, it's often difficult to find the ascending aorta. Here it is over here, tiny little structure. It can be so small that you can miss it entirely. Color flow doesn't seem to help you very much, but sometimes the aorta is larger, particularly when there's avenues of forward flow. Now, I'll just point out the coronary arteries. Although they sort of end organs of the ascending aorta, they are important. We just recently had a patient with an anomalous origin of the left coronary artery from the pulmonary artery in association with this condition. So really, you do have to look at everything in terms of looking at short axis imaging, including the ductus, to make sure that it doesn't show signs of restriction with appropriate doses of indocin. So I think I've said enough about the aortic valves. Now I'll leave that for a moment. Also have left superior vena cava coronary sinuses in some of these patients as well. Now, as far as the size of the ventricle, we have the haberdasher's approach from no left ventricle to a tiny left ventricle, as you see here, to a more small, tiny left ventricle, to a moderate-sized left ventricle, to even a large, dilated, poorly functioning left ventricle. And perhaps that's why Dr. Rudolph is concerned about calling this a hypoplastic left heart, because the left heart ain't so hypoplastic in some of these patients. But having said that, here is the little slit-like amount of tissue associated with mitral atresia, and you can't really see a left ventricle on the ultrasound study. What you can notice over here, of course, is that there's tricuspid regurgitation, which you can see very clearly, and in some even a small left ventricle. Now, one of the things about the left ventricle is we also, in looking at flow, we know that when there's mitral stenosis and aortic atresia, the ventricular pressure may be somewhat elevated, and as perfusion of the ventricle occurs from the inside, from the outside in, and pressure is transmitted from the inside out, that there are probably zones of perfusion of the left ventricle, there's a zone where there is almost an increased amount of flow for the amount of work. There's the middle zone where it's just right, and of course the subendocardial layers can become ischemic and develop endocardial fibroelastosis as we see it here. It's difficult sometimes to see it. This is a transesophageal study. All of these are transesophageal, taken at the time of Norwood. And sometimes you can identify the endocardial fibroelastosis in these restrictive ventricles as well. Here's another example of endocardial fibroelastosis observed morphologically as well as echocardiographically, and I'd like to suggest that you turn up the sensitivity of the grayscale when you look at this so that you can highlight the difference between bright echoes and dull echoes. And I think you can see in many of these specimens the endocardial fibroelastosis together with the papillary muscle scarring that occurs in this condition. And here in the bottom is the ultimate example of endocardial fibroelastosis with a restrictive ventricle. And if this happens in the fetus, when that happens, as my students have told me, when there's no flow, there's no grow, and so the ventricle is confined and remains small at about the time when the injury became profound here. Now, in addition to that, one of the latest things that's been discovered is the association of myocardial perfusion through so-called sinusoids that occur in the left ventricle. And they probably occur in almost all patients as they do in hypoplastic right heart, which we'll be discussing later. And these things are sometimes visible if you look for them. Let me just skip over this for a moment. And I'll get back to that in a moment. Here we're looking at the size of the ascending aorta and just comparing it angiographically, morphologically. Here's the hypoplastic ascending aorta, and here's the pulmonary artery. And you can see same comparable studies here in the ultrasound. With, again, as Steve Sanders had mentioned, the retrograde diastolic flow and perfusion of the ascending aorta in a retrograde manner. Now, we've talked about this restrictive foramen. Dr. Rudolph mentioned it, and here is an example of a fetus that had evidence of restriction. You can see that sometimes the atrial septum becomes aneurysmal over here, as you see it, and you just see the tiny little high-velocity jet coming across the upper part of the septum, which is sometimes deviated to the left side, so-called leftward deviation of septum primum. And the patent foramen may be very tiny, and may be of moderate size, and obviously, as Dr. Rudolph had mentioned, it's important physiologically to understand what's happening, and perhaps this is a cause when you see it postnatally for some kind of an intervention by means of a stent or something, and let the baby recover from the pulmonary edema that it's developed during the course of these procedures. I mentioned hypoplastic left heart with ventricular septal defect. This looks almost like a common arterial trunk, truncus arteriosus. Here's the ventricular septal defect. Here's the questionable, let's call it, overriding great vessel. But here's the tiny little ascending aorta that you see here. So this is a patient who has aortic atresia with a VSD, and under these circumstances, the left ventricle is usually well developed. As you can see here, it doesn't look like much of a problem, and of course, the operative repair for this is a Norwood procedure with closure of the VSD and a conduit from the right ventricle to the amputated pulmonary arteries. So that's something that we always have to take into consideration when you're dealing with patients that look like they might be a truncus arteriosus. And then here's another patient with a VSD. I've compared this one over here. There are two VSDs, a membranous and mid-muscular VSD. And here is a cast which I obtained from Dr. Andrew Cook in London, showing the mitral atresia in this situation, the mid-muscular VSD, the hypoplastic left ventricle, but with forward flow because of the VSD, and yet with a hypoplastic isthmus and the typical type of coarctation that is seen in patients with a hypoplastic left heart syndrome or bananas, or whatever you want to call it. So let me just talk a little bit about the sinusoidal issue. And it can be identified in fetal echocardiograms. And I think if you look here, I'll take my catheter away, you'll see the blush of the flow into the left ventricle as you look at I'll put the arrows to show the blush and the coronary blood flow there. And of course, I think echocardiographically, it's not difficult to see. Again, we, as Dr. Shirali had mentioned earlier on, lower the Nyquist limit. And we can look at this from short axis, from four-chamber, from long axis views. And here, matched up with this, is an example of these big coronary fistulae that you can see coming into these coronaries in a patient with a hypoplastic left heart syndrome, endocardial fibrinoelastosis, and a very normal or enlarged right ventricular size. So that's something that I think that we should see, and I would make a plea always to you to lower the scale of the color to see these vessels, because they're very difficult to see if your Nyquist limit is too high. So if you didn't like that picture, I do have some others, and you can see here at 86, we can't see any sinusoids. But if I take the same picture and I lower the scale down to 24 maximum on the Nyquist limit, you can see these sinusoids very clearly on this example. And here you can see it on an autopsy specimen, the sinusoids with this hypoplastic left ventricle. And here, these things can sometimes be very clearly and recognized. This is from David Robeson, who's written up the whole series of patients with sinusoids that can be identified. And lastly, the levi atrial cardinal vein. It's something like total anomalous pulmonary venous return in that it uses the cardinal system. It's a variety of flow from the pulmonary veins into the superior vena cava system. When this happens, very frequently the pulmonary artery pressure stays up, and so the ductus doesn't constrict. And this is from a 12-year-old patient with levi atrial cardinal vein, and you can see the vein running around and coming into the superior vena cava. Here's the entrance of this left atrium, a little membrane, and from the left pulmonary veins you see this vertical vein coming up and crossing and going into the superior vena cava. So this is the oldest known survivor of a hypoplastic left heart without surgery. Unfortunately, the child was seen at 6 years of age, where she could have undergone a heart transplant, and unfortunately presented to us at a later stage when she had already pulmonary vascular disease developed. So here is a short axis showing what looks like two superior vena cava, a normal right superior vena cava with blue flow going down towards the heart, and a left so-called levi atrial cardinal vein with the flow coming up and going around and going into the superior vena cava. So that's more or less all I've got to say, and I want to thank you for your attention and move on to the next speaker, who's Dr. Friedberg. Yes, you may. Do you want me to put your presentation on? Oh, you want the microphone? Sure.
There's just one thing that I wanted to add to my comments relating to pulmonary and systemic vascular resistance. I mentioned that the distribution of blood to the systemic circulation depends on what the ratio of pulmonary to systemic vascular resistance is. And you can imagine that if you wanted to improve systemic blood flow, you could do it by increasing pulmonary vascular resistance. And this has been attempted now. Some people have recommended administering about 15% oxygen to these babies who have a problem with systemic circulation, and 15% oxygen produces pulmonary vasoconstriction, And with this increase in pulmonary vascular resistance, you can improve systemic flow. Now, it's interesting because what this does is it drops oxygen saturation, but of the mixed blood, obviously. But even though oxygen saturation falls, there's better delivery of oxygen to the tissues. So this relationship between the two is very important.
You have a question here?
Restricted. You said in the fetus you use the pulmonary venous flow pattern. Would you use it in a newborn as well? Is it of the same value?
Okay. So I'm aware that we're out of the formal time for this session, and I'm being asked to start a session under duress. Huh? Okay. So we're going to talk about some of the functional aspects of hypoplastic left heart syndrome, of which there are many. Here's just an example again from DICOM images where if you just looked at this heart, you would say good function by subjective assessment. And I'll come back to this later, but not only do you have markedly reduced strain in the RV lateral wall, this is quite typical to see the stretching of the septum of this myocardial mass there, contributing, in my opinion, to ventricular inefficiency, and we'll get to that. And if you look at the strain pattern itself on the right ventricular free wall, it's very abnormal. So not only is it reduced, it's abnormal, and there are interactions between different segments in the right ventricle. You've heard some of the considerations that might contribute to dysfunction of the right ventricle in this situation. There are many, besides the abnormal loading conditions at various stages of the palliation. You might have intrinsic myocardial abnormalities, and Norman brought up the issue of sinusoids and whether that contributes to ischemia and poor outcomes. There are papers suggesting strongly so and other papers suggesting less so. So I still think that that's an unresolved issue, and different people counsel fetal counseling differently when that's seen. One thing is clear, that right ventricular function is a critical determinant of outcome in this syndrome. And even though we all recognize that, there's shockingly little literature to suggest so. This is Karen Altman's paper from New York, and she showed just qualitatively, and here's the score, it's just qualitative assessment of function, either survivors of Norwood or just all babies after Norwood. If you've got reduced ventricular function, your survival is less, and it's less markedly so. You've got a hazard of mortality or a relative risk 11 times greater. And of those that died, you can see that most of these, from various reasons, but most of these developed right ventricular dysfunction. So right ventricular dysfunction, subjectively or by other measures, is a critical determinant of outcome, at least by this paper, and I wish there were more to say that. One of the aspects of ventricular dysfunction that is both a result of the dysfunction and a contributor to dysfunction, I think, is tricuspid regurgitation. And this is from Sano's data. You can see that if there is tricuspid regurgitation, your outcome is poorer, and that's been shown in other studies as well. I won't go into the actual methodology, but just this is from Tom Kimball's data from years ago, automated border imaging, just to stress that we don't only have systolic abnormalities, but there are diastolic abnormalities as filling as well. And I've tried to stress this along the lectures, that there's almost always abnormalities of both systolic and diastolic function, of right and left ventricular function. So obviously the left ventricle here is hypoplastic, so we don't talk about dysfunction. It's obviously dysfunctional, but there's abnormalities of both. Some people have shown these abnormalities by myocardial performance index. Norman and I have published the systolic to diastolic ratio as abnormal in these infants. And I'll show you this again in dilated cardiomyopathy. I think this is what is interesting, although we both have not gotten to the bottom of this, and this needs to be done, I think. If obviously diastolic time is a function of heart rate, that's obvious. There's a logarithmic kind of association. So is systolic time, less related, it's linear. If you take the systolic to diastolic ratio, it's obviously going to be influenced by heart rate. In the squares here are the patients at various stages, and we try to differentiate this. And if you take the controls, it's the open circles. This is a cross-sectional study. It's not an exercise study. But you can see that as heart rate gets faster, the controls, despite the normal change in diastolic time, are able to maintain sufficient diastole, which we think, this needs to be proved, allows for sufficient filling. You saw that the patients have abnormalities of filling rate and may affect coronary perfusion. We haven't proven that. The hypoplastic on the other side, when you're at slow heart rates, you're fine. You have sufficient diastolic time. But as you increase your heart rate, they are unable to maintain that ratio, and diastole shortens proportionately more than systole. And we didn't prove that this was related to abnormalities, but I think that this may be a basis for many of the abnormalities. Now, onto a different topic. Over the years, people have proposed that this dysfunctional left ventricle somehow impedes right ventricular function, either because it's a dead weight, if you will, on the right ventricle, an effective afterload, etc., and there may be something to that in abnormal ventricular interactions. This is data out of Toronto. Steve Schwartz was the senior author here, that showed that this is the length of the interventricular septum as a surrogate for left ventricular size. Not the best surrogate, but this is what they used. And you can see that in model data, this was quite strongly associated with survival. In fact, almost as much as ejection fraction, which we said. We know that right ventricular dysfunction is a parameter. This is right ventricular ejection fraction. And here are other things that were associated with mortality or transplantation. There are other studies suggesting or saying that left ventricular size is not clearly related to outcome. So this is another one of those things that I think still needs to be sorted out, but maybe there is some evidence for that. Now, there's been a lot of research trying to moving on to stage 1, most of the mortality, as you know, is around stage 1 and interstage mortality between stage 1 and stage 2. So there's been quite a lot of research altogether. Are there benefits to a certain type of stage 1 procedure? And most of the research is focused on BT shunt versus the RV to PA conduit. And Peter Frommold looked at this in a number of echo indices between RV to PA conduit and BT shunt. And while there may have been some abnormalities in some of the parameters at some of the stages, overall there didn't seem to be huge differences. Mainly the difference was an eccentricity index, which might be a reflection of the loading of the ventricle. We all know of the Pediatric Heart Network single ventricle trial, which ultimately over here didn't show a significant difference between the two, although at a year there was a difference in transplant-free survival. This is data from Dan Penny's group, a very small number of infants, but this is what we have out there in terms of strain, showing these are the two infants. The infants in circles are the one with the the BT shunt, and the triangles are the RV to PA conduit. The 2 out of 7 that died had a shunt, and the strain seemed to be better overall in the group with the RV to PA conduit. 7 infants, I think, it's very difficult to draw conclusions. This is the type of data, though, that we have out there. More recently, Shaji Menon, when he was in Utah, I think, showed, though, that around the RV to PA conduit, you have decreased velocities and decreased strain. So I'm glad everyone's sitting down, but you know, we wouldn't have been shocked by that. But I think this just reminds us that we're doing a ventriculotomy in a ventricle that's dysfunctional and is the only ventricle, and we're going to get abnormalities of function around there. I want to talk about this, Matthias, because It's a subject that's close to my heart. Norma's telling me to stop. Is 5 minutes okay? So 4. This is the issue of mechanical dysynchrony, and it's a tough issue because there's electrical activation and there's mechanical motion. Here's a heart which is you can see it's desynchronous, and there's also changes between various segments in the amount of deformation, which isn't exactly mechanical dysynchrony. We looked at this a number of years ago, and by strain found that these infants in the right ventricle have mechanical dysynchrony, although we were unable to associate this clearly with the QRS. But again, they're subjects at different stages of palliation, and it seemed to improve if you had if you had less loading, which we know infants improve overall. And there was some association with right ventricular function, although not a very strong one. But again, we were unable to show that this was associated with QRS duration. And here is the improvement, if you will, between stages. More recently, based on that work, Nisa Koo in Edmonton in Alberta, Canada, showed, in fact, that having less dysynchrony by strain imaging was associated with improved function in a number of parameters. More recently, I began to think, well, we know that TR is a significant risk factor, and we know that in adults, if you have mechanical dysynchrony due to abnormal motion of the papillary muscles and the support of the papillary muscles, you get more mitral regurgitation. Does this happen in hypoplastic left heart syndrome? Now, I'm not suggesting for a moment that there aren't a lot of causes for anatomical causes, and as Dr. Sanders showed, also dilatation of the ventricle and abnormal placement, if you will, or position of the papillary muscles and supporting apparatus. But we looked at this and we tried to sort it out with the anatomical abnormalities. And what we found, and I think this may be true looking at the base of the heart, is that there is a difference, obviously, in the strain developed in the septum, which is highly abnormal, and the right ventricular free wall. So if you have both abnormalities in timing and in the peak strain, does this distort the annulus, increasing tricuspid regurgitation? We found that no one has accepted the paper so far, so it's in this endless circuit of current echocardiography. Anyway, Nisa Koo in that paper I showed you also talked about, and I mentioned this when I talked about the systemic right ventricle, about changes in adaptation. I'd be wary of this data. I'm not saying it's incorrect. I just think that they perhaps didn't show it. But what they suggested is that there's a decrease in longitudinal parameters between stage 1 and stage 2. We know that. And they suggested, based on some of the ratios, that there was an increase in circumferential strain, just like I showed you for the systemic RV. I actually think that they showed lower strain rates. So I'm not sure that the data actually showed what they're proposing. But other authors, Shaji Menon again, showed the same thing. I think it's very difficult to measure circumferential strain in the right ventricle. So I'm always a bit skeptical of this data, and we certainly don't obtain reliable right ventricular circumferential strain, but I'm just showing you what's out there and just food for thought in what these right ventricles do over time. And I showed you this work in systemic RVs showing these adaptive changes. So perhaps they're true, but I think we need better tools to show it better. So I'll end there.